25. A pleasant good afternoon. My name is Kareem Smith. I am the project coordinator for the Caribbean Future Forum. Today, I'd like to welcome you to another episode of our CaribWebDialogue series aimed at raising awareness of the Sustainable Development Goals, commonly referred to as the SDGs, and their relevance to the Caribbean region. Today, we're focusing on good health and well-being, which is Goal 3 of the SDGs. We did have 2 webinars in April that also focused on health and non-communicable diseases in the Caribbean region. And today we're looking at the strategy known as Health in All Policies. To discuss this topic with you, we are pleased to have with us Sir Michael Mamat. A very warm welcome to you.
Thank you.
And just to give you a brief history of Sir Mamat's involvement in this area. He is the director of the Institute of Health Equity and also a professor of epidemiology at the University College London and president of the World Medical Association. He is the author of The Health Gap, The Challenge of an Unequal World, and Status Syndrome, How Your Place on the Social Gradient Directly Affects Your Health. He holds the Harvard Loan, is that correct? Professorship for 2014 to 2017 and is the recipient of the Prince Mahidol Award for Public Health 2015. He has been awarded honorary doctorates from 16 universities. He has led research groups on health inequalities for 40 years. He was the chair of the Commission on Social Determinants of Health, which was set up by the World Health Organization in 2005. And produced a report entitled Closing the Gap in a Generation in August 2008, At the request of the British government, he conducted the Strategic Review of Health Inequalities in England post-2010, which published its report, Fair Society and Healthy Lives, in February 2010. This was followed by the European Review of Social Determinants of Health and the Health Divide for WHO Euro in 2014. He chaired the Breast Screening Review for the NHS National Cancer Action Team and was a member of the Lancet University of Oslo Commission on Global Governance for Health. He set up the Whitehall 2 studies of British civil servants investigating explanations for the striking inverse social gradient in morbidity and mortality. He leads the English longitudinal study of aging and is engaged in several international research efforts on the social determinants of health. He served as president of the British Medical Association in 2010 to 2011 and is president of the British Lung Foundation. He is an honorary fellow of the American College of Epidemiology, a fellow of the Academy of Medical Sciences, an honorary fellow of the British Academy, and an honorary fellow of the Faculty of Public Health of the Royal College of Physicians. He was a member of the Royal Commission on Environmental Pollution for 6 years, and in 2000, he was knighted by Her Majesty the Queen for services to epidemiology and the understanding of health inequalities. Internationally acclaimed, Professor Mamat is a foreign associate member of the Institute of Medicine and a former vice president of the Academia Europea. And just before handing over to Sir Mamat, I'd like to remind you to stay up to date with our current activities via our website, CaribbeanFutureForum.com, our Facebook page, Caribbean Future Forum, and our Twitter at Forum_Caribbean. Please do feel free throughout this webinar to submit your questions and comment, and they will be answered live. So now, without further ado, I'd like to hand over the floor to Sir Mamat.
Thank you. As I sit here, I can see posters, 17 of them, one for each of the Sustainable Development Goals. Goal number 3 is about good health and well-being. One approach to health in the context of development is that health is one indicator, along with 16 others, of sustainable development. A second approach is that health is a contributor, so not just one indicator of development, but it's actually a contributor to economic development. Improve health of individuals and they'll get richer. Improve health of populations and the societies will get richer. There is a third approach, and it's that third approach that led to my chairing the WHO Commission on Social Determinants of Health. And that third approach is that social determinants, other features of development, impact on health and health inequalities. And that was the text, as it were, of the Commission on Social Determinants of Health. When we reported in 2008, closing the gap in a generation, we pointed to a more than 40-year gap in life expectancy across the world, inequalities of life expectancy within countries as big as 28 years for men in Glasgow. And we said that gap could be closed in a generation, potentially, by action on the social determinants of health. When I went to see Helen Clark, the administrator of the UNDP, I said to her that what UNDP does in its day job impacts on health. And in fact, she invited me then to come to a meeting of UNDP, the Southeastern European region, where I put that very point to them, that they shouldn't just be thinking, well, we need better healthcare to get better health, and that'll be a contributor to development. That's very important to have good healthcare and better health. But they should recognize that what they do in their day job in terms of development impacts on health. Think of the Human Development Index, 3 components: health, education, literacy, and income. My own approach to that is the other 2 are, to some extent, determinant of good health and narrow health inequalities. And indeed, my approach to the 17 SDGs is that most of the other 16 will have impact on health and health inequalities. No poverty, zero hunger, quality education, gender equality, I'm looking around the wall as I speak, clean water and sanitation, affordable and clean energy, decent work and economic growth, one after the other. Reduced inequalities, sustainable cities and communities are all determinants of health. So from my point of view, health and health inequalities are outcomes of sustainable development. In fact, they're very good markers of how well we're doing. I was at a meeting in Stockholm at the beginning of 2013, and a member of the Swedish Parliament said, most Commission reports have a half-life of about 6 weeks. They get forgotten pretty well after about 6 weeks. Your report, he said, referring to the WHO Commission on Social Determinants of Health, is still being discussed in the Swedish Parliament 5 years later. And he invited me to come to the Parliament next time I was in Stockholm, and I did a few months later. And I said to the parliamentarians there, I've just come from a meeting of the Swedish Association of Local Authorities and Regions. There were something like 300 people in the room representing all the local areas in Sweden. And they were all so enthusiastic about taking on board social determinants of health as a guiding framework for what they were doing in their communities. So I said to these members of the National Parliament, I'm delighted that you are still discussing the WHO Commission report. I'd be even more pleased if you did something about it. And in fact, you'll find that all across Sweden, local authorities and regions are acting on it. It would be great if the national government did it too. And in fact, Sweden has now set up a national commission on social determinants of health. Colleagues of mine say, why do you go to Sweden? Why aren't you going to Ethiopia? Does Sweden really need more action on social determinants of health? They have good health, relatively narrow inequalities. Do they need to do more? Well, the Swedes feel they need to do more. And so I start with Sweden because there's a country with remarkably good health on a global scale and remarkably narrow inequalities in health. For example, life expectancy for those with primary education compared with those with university education, the difference is quite small. And on a European scale, they are among the smallest. But even they in Sweden feel there's much they need to be doing about social determinants of health. And that means the rest of us in countries rich, middle income and low income have a great deal to do. If even the Nordic countries think this is crucial, the rest of us have a lot of catching up to do. It's something for all of us. Let me say one other thing about how come I happen to be in Port of Spain in Trinidad and Tobago at the moment. I've spent my professional life saying that the key determinants of health are not what doctors do for patients. They lie outside the healthcare system. When people get sick, they need high quality healthcare and good access to high quality healthcare. But it's not lack of healthcare that causes sickness in the first place. It's the environment in which people are born, grow, live, work, and age. In other words, the social determinants of health. And then I found myself president of the World Medical Association, an organization that represents national medical associations globally. So I've been arguing that's not what doctors do for patients. And here am I, notionally, a leader of the world's doctors. And what I've been saying is that there's much that doctors can do, and indeed the health sector can do, in addressing social determinants of health. Dr. Suleiman Juman, who is the president of the Commonwealth Medical Association, a surgeon based in Port of Spain, said, you must come to Trinidad and Tobago. We need your message here. So here I am at the invitation of the Medical Association of Trinidad and Tobago, the Commonwealth Medical Association, the Pan American Health Organization, Ministry of Health, other sponsors. And we've had a very full 3 days of meetings. And the Ministry of Health has declared themselves absolutely ready to take on this agenda of social determinants of health. But it needs much more than the buy-in from the Ministry of Health. It needs buy-in from the whole of government, and indeed the whole of society. But my argument is that health and health inequalities tell us a great deal about how well society is functioning. And that's why when I think about the social development goals, the sustainable development goals, the SDGs, I think about 16 of them as being input to goal 3, which is good health and well-being, as a good measure of how we're doing. And indeed, I hope that as countries move to try and get measurements, indicators as measuring progress on the SDGs, they'll at least think about a subset of those indicators in the framework of social determinants of health, because the stakes are high. We said on the cover of the report of the Commission on Social Determinants of Health, social injustice is killing on a grand scale. The endeavour to improve health and reduce health inequalities is one of social justice. And those of us who are working to achieve greater health equity are working to achieve more just societies. And now I'm open for questions.
Okay, great. Thank you so much. We're going to invite our audience to continue submitting questions, and I'm going to proceed with the first question. So it comes from Maria Henry, and she asks, how do we achieve positive behavioral change in prevention?
To achieve positive behavioral change, people ask, well, health education, isn't that the thing we need? And my response to that is, it's necessary but not sufficient. Conveying information about risks to health has the possibility, if not the probability, of increasing inequalities in health. Convey a message about healthy food. Who listens? The chattering classes. People who are highly educated will be listening to the message and asking, what can they do? People living in increasing degrees of deprivation and poverty will have other priorities. They'll be worrying not so much about healthy food, but about food. Can they eat at all? Can they feed their children? Do they have work? Do they have clean water? So that achieving positive behavior change, information is not enough. I talk about behavior as being among the causes of ill health, but we need to address the causes of the causes. So if you want people to give up smoking, that's a positive behavior change. You've got to recognize that increasingly in country after country, smoking follows the social gradient. In other words, the lower people are in the social hierarchy, the more likely they are to be smoking. If we want really to do something about positive behavioral change, we have to empower people. We have to give them the means to take control over their lives. And that means investing in early child development and good education through the life course, not simply conveying information.
That's true. Thank you for that. And our second question is, what about the cultural beliefs and internalized factors that may perpetuate these health inequalities? What mechanisms should be used to factor this in developing and implementing policies?
It's an excellent question. We, of course, must be respectful of people's cultural beliefs. But where cultural beliefs are damaging health, we've got to confront them. So let me take two examples. One is female genital mutilation, FGM, and the other is violence to women, domestic violence. If it's part of a cultural belief that FGM is the norm, we know that's damaging the health of young girls and of women. We need to address that issue, not simply say, well, that's part of the cultural belief to damage the health and well-being of girls and women. We respect that culture. We've got to confront the culture that may be damaging women. And similarly, gender-based violence. We have evidence from demographic and health surveys that in some countries, particularly in sub-Saharan Africa, women claim that it's acceptable for a husband to beat his wife if she refuses to have sex with him. I think we have to say the right of a woman to be treated with dignity is more important than the cultural belief. Now, you might say they're egregious examples, but it seems to me, apart from those extreme examples, it ought to be possible to be respecting cultural beliefs and creating the conditions for good health at the same time.
So thank you so much. And we have a two-part question from the recent discussions in Port of Spain. So one would be, should the health system in the Caribbean expand to take on the social determinants, or should that be left to another sector? And if so, who would be the best non-medical partner for the ministries of health without spreading the health dossier too wide for impact?
My answer to questions of the should it be this or should it be that variety commonly is yes. It should be this and it should be that. So I think the health sector can indeed take on responsibility for social determinants of health, and it should be working with others. What do I mean by that? Suppose you're a pediatrician and you're working with young children. To ignore healthy child development would be not to practice medicine very well. But you might say, well, I'm not a specialist in cognitive and linguistic development, social and emotional development, behavioral development of children. I recognize that that is important for health, but I'm not an expert in that. Then you should be working with people who are expert in that area. I talked a moment ago about domestic violence. You may, as a practicing physician, say, I'm not an expert on how to deal with issues of domestic violence. But you know what? There are people who are expert. So the health sector, at least in part, should be working in partnership with others. So when you ask whose responsibility is it, I say, yes, it is the responsibility of the health sector, but it's also the responsibility of education and the Ministry of Finance and the Ministry of Environment and whoever it is who looks after workplaces and social protection. All of these sectors that have an impact on the social determinants of health should be responsible. And the health sector should be working in partnership with them.
And how would you advise on an approach to a national breastfeeding policy?
It's a prime example of addressing the causes of the causes. Overwhelmingly, we know that breastfeeding benefits the next generation. It probably benefits the mother as well. So overwhelmingly, we know that. So then we have to address the issues that may be barriers to women breastfeeding. What do they need to be able to do this? If they're working, do they need the conditions at work to allow this to happen? Are women themselves malnourished or suffering from infections and not best placed to be breastfeeding? Overwhelmingly, we know that breastfeeding is the best option, but it's a prime example of needing both health education and creating the conditions that make this possible.
Thank you. We have sort of a question comment. It's, why is social and emotional health and well-being not given as much attention when it is really at the core of all we do?
Why is it not given so much attention? I'm not sure I know the answer to that. I mean, implicit in your question is it should be given this sort of attention, and I agree with that 100%. Indeed, it should. We know, looking at the global burden of disease, for adults, The single biggest contributor to morbidity, to disability adjusted life years, to morbidity globally, is unipolar depression. If we ignore mental illness, we're ignoring one of the major consequences of the social determinants of health and one of the major contributors or components of inequalities in health. Part of the reason why it's not given the same attention as physical illness is prejudice. There's widespread prejudice against people with disability. And I think that probably includes people with mental illness. And somehow a feeling that mental illness, perhaps, I'm not reflecting my view, but mental illness perhaps is some sign of mental weakness. There's a sense that people should pull their socks up and behave better, whereas physical illness is obviously something that you couldn't do much about. I mean, I think there's some sort of feeling like that. Whereas in fact, we know that mental illness can be fatal with high rates of suicide. We know that people with mental illness, on average, have life expectancy about 10 years fewer than people without mental illness. So even if your concern was mainly with physical illness, you still should be concerned with mental illness because of its impact on physical illness. Now, I think you should be concerned with mental illness for its own sake. And to come back to your question, well, why isn't it featuring as strongly as physical illness? I suppose because those of us who recognize how important it is have not been doing our job properly in raising awareness of its importance. And the fact, from my point of view, that if you're concerned about social determinants of health and health inequalities, you have to be concerned about mental illness. And if you're concerned about mental illness, you have to be concerned about social determinants of health because they're so intimately related.
Thank you. And would you suggest taxes on unhealthy foods that are high sugar, high fat, high sodium, for example, to encourage the use of healthier foods and allow such taxes to contribute to the healthcare system?
Well, the first thing is we need to look at the evidence, and the evidence is not abundant about the effects of taxing unhealthy foods. My understanding of the evidence from Mexico is that a sugar tax did in fact affect the consumption of sugar-sweetened beverages. And when we look at what we know about obesity, overwhelmingly, the strongest proximate, and I'll come to what I mean by proximate in a moment, the strongest proximate cause of obesity, the strongest evidence relates to sugar-sweetened beverages. So if a sugar tax reduces consumption of sugar-sweetened beverages, then I would support it. And I think such preliminary evidence as we have suggests it probably is effective. On the second part, would I then use that tax to fund healthcare? Economists and people who work in ministries of finance, in general, are very much against hypothecation. And by that they mean taking a tax from one thing and using it specifically for something else. Should we use tax on tobacco for healthcare? They're very much against that because it reduces the freedom of government to make decisions. So I'm not going to argue against that antipathy to hypothecation. I think you could make a case that tax on tobacco, tax on alcohol, tax on sugar-sweetened beverages, high sugar content foods have a good health case to be made for them, with a proviso. And the proviso takes smoking. As I said a little earlier, in country after country, we see that smoking is more common in people of lower socioeconomic status. That means tax on tobacco is regressive. The people who are paying that tax are people of lower income. So that's redistributing income from smokers to non-smokers, effectively, the smokers being low status and the non-smokers being high status. I'm a bit concerned about that. I've always supported tax on tobacco, but I am upset about the regressive nature of it. And it means that it should be in the context of addressing the tax and benefit system in a more progressive way. So if we're going to have consumption taxes that are regressive, we need to have a progressive tax and benefit system to counter it. Now, I said I'd come back to what I meant by proximate. When I said that sugar-sweetened beverages are a proximate cause of obesity, the more distal cause comes back to my phrase, the causes of the causes. Why are people consuming sugar-sweetened beverages? Why, for example, does Mexico have the highest consumption per person of Coca-Cola? Nearly 2 8-ounce servings per person per day, according to Coca-Cola's own figures. And we know Mexico has the highest prevalence of obesity documented, and very high prevalence of diabetes. So we need to be working our way back up the causal chain to ask why this high consumption of Coca-Cola and what we can do about it, not simply say, don't drink Coke.
Thank you so much. We have another question that comes from Suriname. So it's, if I understand well, HIAP is cutting through different segments, for example, education and early childhood. So could you please elaborate more on this? And I guess it's how does the strategy cut through these sectors?
Well, I was delighted to visit Suriname last year. There's not many people from the UK who can say that they've been delighted to visit Suriname. I tested my children out if they knew the capital of Suriname. I'll probably say it wrongly. Paramaribo.
Yeah.
Is that how you say it?
I mean, I say it like that, but I don't know if that's how.
And Paramaribo.
Yeah.
So I was delighted to be in Suriname and delighted with the fact that Suriname very much is addressing whole of government approaches and health and all policies. And in fact, when I met the First Lady of Suriname, she made clear that a priority for her is early child development. And I think that's a measure that has an important impact on health and health inequalities, but action on it is not necessarily the province of the health sector. It needs to be given priority within government. Different governments organize these things in different ways. It may be that it's within the Department of Education or something like that. And we know that preschool makes a big difference. The evidence is from country after country. This comes from the Program of International Student Assessment done by OECD. Look at my UN colleague here. It is OECD, I think, that does the PISA. And what PISA shows is that children who went to preschool, attended at 1 year or more of preschool, score better at age 15 on measures of mathematics, literacy, and science. So attendance at preschool has an enduring benefit in educational performance, which in turn will improve people's prospects in adult life. So preschool attendance in age 3 to 5 is vitally important. And then I hear you say, well, what about age 0 to 3? Well, again, the evidence is supporting families to address this social gradient in early child development can make a huge difference.
Thank you. And I've seen this early child health development being incorporated in a lot of Caribbean countries. I think Jamaica is pioneering a project on that as well. So let me move on to the other questions. What are your thoughts on the implementation of NCDs in countries like Trinidad and Tobago? Are you aware of existing hindrances or challenges that we should be aware of?
When we published the report of the WHO Commission on Social Determinants of Health with the title, Closing the Gap in a Generation, I said that closing the gap in a generation was not a prediction, but it was a statement that we have the knowledge to close the gap in a generation. We have the means to close the gap in a generation. The question is, do we have the political will? And I think the major question in Trinidad and Tobago is whether there is the political will. Now, at this conference that was organized by the Medical Association, Trinidad and Tobago, PAHO, Commonwealth Medical Association, and others, on Sunday, the Minister of Health said publicly that he is effectively the Minister of Health Care, but he wanted to change, and he wanted his legacy to be that he would be the Minister of Health. And he expressed his enthusiasm for health and all policies and action on social determinants of health. So I think the barrier in Trinidad and Tobago has been political will. I was with a Roman Catholic priest yesterday. Feels like I've been here for weeks, but on Monday morning, and we were walking along the street in Port of Spain, and a man literally got up from the street where he'd been sleeping and talked to the padre, and they had a conversation. And while we were walking along, we passed 3 other men who were sleeping on the street. And Father Harvey said to me that there is a real problem of homelessness and sleeping on the street. And I said, well, what's being done about it? He said, nothing. There hasn't been the political will to deal with it. We know what to do about people sleeping on the street, provide shelter. And that ought to be possible. I know that people are very concerned that with the collapse in the oil price, that the country is not as rich as it was, but it will be again. And it's not so poor that it couldn't provide shelter for people sleeping on the streets. Now, I don't think action on social determinants of health is confined to the down and out and the homeless. I talk about the social gradient, where you are in the hierarchy affects your health and well-being. But we need to galvanize political will. And I'm optimistic. What I've been hearing and seeing in the couple of days that I've been in Trinidad and Tobago makes me optimistic that the political will is there and is growing.
Okay, thank you. And while HIAP is mostly targeted to the policymakers, what can be done on an individual level to include the social determinants of health in everyday life?
It's hard for individuals to act on their own on these issues. An individual can treat their children well, can have healthy behaviors, and so on. But what we know is that the likelihood of having the conditions that allow you to treat your children well are influenced by where you are in the social hierarchy. the greater the degree of deprivation. What the evidence shows is the less parental input into children and the less children flourish. And that means it's not up to individuals alone to do this. In the end, individuals behave. They cuddle their children and talk to their children and read to their children, or they don't. So in the end, or they eat healthy foods or they don't. They drink alcohol, they don't. They use ganja or they don't. It's up to individuals in the end to behave. But we know social conditions influence the likelihood of individuals doing that. So my real answer to your question, what can individuals do? And the answer is join a group, recognize, be part of a lobby organization, become part of civil society, realize that real change comes by social action. Women didn't get the vote because individual women said, give me the vote. Women got the vote because of an organized movement for female suffrage. Civil rights didn't come from individuals saying, give me my civil rights. They came from an organized movement to develop civil rights, and so on. So what individuals can do is become part of an organized movement.
Thank you. And I think we have time for just one more question. So it would be, at the CARICOM level, what recommendations would you have for decision makers to sort of include that HIAP across the region?
We think of different levels of action. We've just been discussing individuals, and I'd say, well, really it ought to be groups. Local government is important because local government relates to communities. National governments are important, and in small island states, the population of the local authority, the London Borough of Camden, where I live and work, the population's 250,000. So there are a lot of island states in the Caribbean that probably don't have populations of 250,000. So talking about the local authority level perhaps is less appropriate, but still, families, groups, local government, national government, and transnational is important as well, and that's where CARICOM comes in. Sharing knowledge and expertise, dealing as a bloc with good trading arrangements that are likely to be important. Trading arrangements are vitally important. Dealing with international finance is likely to be important. We talked in the WHO Commission report about fair financing. So trade, debt, financing, global arrangements, CARICOM is likely to pull more weight than a single country alone, quite apart from sharing knowledge and information and pooling intellectual resources across the Caribbean. So I think CARICOM has a key role to play.
Mm-hmm. Okay, thank you so much. So I know that we are currently out of time. So I would like to thank you very much for being with us here today. Thank you to our audience for your participation and for sending in your questions. I know we have just about 2 questions that we weren't able to cover within time. Do continue to keep up to date with our websites and our social media pages. You can continue to have your discussions here. So Mama, thank you very much for this fruitful discussion. I'm not sure if you'd like to say anything in closing to the audience.
Well, I'd like to thank everybody, but I couldn't see anybody, so I wasn't quite sure who was on the end of this. It felt like a one-way conversation, but I'm very grateful for the good questions that people sent in. And if I could see you, I'd say it's been nice to be with you, but I can't quite see you.
We can share our list of participants so that at least we know the names of persons and countries they've come from. So thank you very much. And to our audience, do enjoy the rest of your day. And yes, we will continue this discussion. We do have another webinar coming up in August, and it will be on the 9th of August. So stay tuned for that. Thank you.